Good afternoon. I know this is the last presentation. First of all, I would like to thank Professor Kamal Okasha for the kind invitation and nice introduction. And this is a fantastic meeting of the 9th annual conference of Tanta Nephrology Unit. So I'm going to highlight rapidly some important pearls in nephrology published this year. In glomerulonephritis, I think Mentor trial, which compared rituximab to cyclosporin in treating membranous nephropathy. This Mentor trial is considered a change in the paradigm of management of membranous nephropathy. So after 6 months, rituximab is not inferior to daily cyclosporin. And more importantly, after 2 years, the remission here in rituximab is 60% in comparison to 20% in cyclosporin. This means that rituximab is coming to treatment of membranous nephropathy, and it seems that the editorial comment will be proven by the new trials and the coming trials. Treatment of idiopathic membranous nephropathy in adults, KDIGO, cyclophosphamide, and cyclosporin A are out. Rituximab is in the new normal and on the way. But it seems that from this commentary that we need more and more studies, because in this small number of patients, remission is induced in 82% when we combine rituximab plus cyclosporin. So we are waiting the waves of research in treating and the refinement of treatment of membranous nephropathy. Lupus nephritis is very, very interesting issue in nephrology. I'm not going to discuss details of lupus nephritis, but I want to refer to this issue, special issue of this journal, Advances in Chronic Kidney Disease, Lupus Nephritis and Vascular Disease. All these are articles discussing lupus nephritis. I want just to highlight, we shouldn't forget antiphospholipid serology, because antiphospholipid positivity is associated with a poorer renal outcome. Number two, when the patient has end-stage kidney disease due to lupus, would like to know seropositivity for antiphospholipid. It is more crucial than even antinuclear antibodies and anti-DNA. Why? Because this will dictate the use of either antiplatelet if there is no thrombophilia, or anticoagulation if there is history of thrombophilia. It seems in the future, the use of biologics will be developed, and the growing field is the dependence upon surveillance biopsy to guide us for refinement of maintenance therapy. For acute kidney injury, for ANCA-Associated Vasculitis, this is the very nice updated core curriculum management. And here we depends upon the ELISA, because we have immunofluorescence. This was an old, and then we have the recent ELISA to discriminate if there is proteinase 3 ANCA or MBO ANCA. Why? Because MBO ANCA, the relapse is lower than proteinase 3, and the clinical trial shows that we can use in the induction MMF. So induction of MBO ANCA positivity, if this is a new diagnostic case, using rituximab plus steroid, cyclophosphamide plus steroid, or MMF plus steroid. And if the case relapses, we don't use MMF, we use rituximab plus glucocorticoid. And the maintenance, either rituximab or azacitidine. If it's proteinase 3 ANCA, we don't use in the induction mycophenolate mofetil, and in the maintenance, we use rituximab or azacitidine. So this is very nice. The second point in ANCA-associated vasculitis, the role of plasma exchange is very limited. And it seems it is restricted to overlap syndrome between ANCA positive and anti-GBM. And so the role of plasma exchange is declining. In chronic kidney disease, I'm stressing upon the use of medication, because drug use or side effects or abuse of the drugs is considered the third cause of mortality after cardiovascular and cancer. And here in this is from pediatric paper showing that pediatric with chronic kidney disease patients are treated with the nephrotoxic drugs. So we should take care of all these points. And this is the same scenario in adults. Diabetic kidney disease is one of the most common causes of chronic kidney disease. And this year we have a landmark trial published in New England Journal of Medicine about the use of canagliflozin, a member of sodium glucose cotransporter 2 inhibitors. And this is one of the important studies in the nephrology, because here the primary endpoint is not hyperglycemia treatment, but renal outcome in type 2 diabetes. This study was prematurely terminated because of beneficial effects on renal endpoints. Each arm included more than 2,000 cases, and this is an abstract from the renal WEEKE, addresses the difference between the meta-analysis, including large number of participants. They compare the results of GLP-1 receptor agonist, as you see, could attenuate the incidence of new albuminuria and renal composite outcome. DB4 inhibitors only prevent the incidence of new albuminuria or regress albuminuria, and it is debated regarding renal outcome. And the most important, sodium glucose cotransporter inhibitors exhibited nephroprotective effects in terms of regressing albuminuria, preventing the incidence of new albuminuria, doubling creatinine, RRT, renal replacement therapy, need dialysis, renal composite outcome, heart failure, and mortality, solid outcome. To the extent that this was the cover image of the NDT this month, December, renoprotective effect of sodium glucose cotransporter inhibitors are highlighted here. But be careful, we don't use this class of drugs if estimated GFR less than 30 milli per minute, because there is no trials in addressing this point. And to avoid, to be cautious in elderly because of the risk of malnutrition, because of glucoretic effects of this class, and in the patients with type 1 diabetes and patients exposed to surgery, to avoid them until we have, for type 1 diabetes, until we have evidence, but we should stop them before surgery. Why? Because of the risk of ketogenesis, because this class of drugs is associated with increased glucagon and reduced insulin. This environment will increase ketogenesis and lipolysis. Unfortunately, urine analysis may be deceiving because these drugs stimulate kidney to reabsorb keto acids. So if we want to document, we should depend upon serum beta-hydroxybutyrate rather than urine acetone. So this is the, and we can pick the diagnosis if we consider blood gases, acidosis, and absence of lactate. If euglycemic ketoacidosis is the diagnosis, the treatment is IV glucose and insulin. And I think the plenary presentation of Professor Rashid Barsoum is fantastic regarding diabetes and obesity challenging nephrology. Regarding dialysis, the philosophy of renal replacement therapy, yes, we would like to remove toxins, fluid overload, and even prolonging survival, but the most important objective is to offer better quality of life. One of very smart articles, I like it because it addresses the use of sodium bicarbonate, which is available everywhere, the concentrated one, 10 milliliter in each catheter lock, port at the end of the dialysis as catheter lock. In comparison to saline, as you see, the overall side effects is significantly lower with the use of bicarb. Thrombosis is very low, and catheter-related bacterial infection is very low. So it seems that it is cheap lock that we can use. Cognitive function is the most important function in the body, brain functions. And the cognitive impairment is so prevalent in dialysis patients. Up to 70% of dialysis patients have one degree or another of cognitive impairment. And the pathophysiology of cognitive impairment, the causes and pathophysiology are intricate, but I would like to focus on intradialytic hypotension that reduces cerebral perfusion. This is why we should avoid intradialytic hypotension, and we may use interventions like dialysate cooling, because dialysate cooling is very cheap modality, just to reduce temperature below 0.5 degrees centigrade below the core temperature. It will help the brain to function well, as shown from a trial depending upon functional MRI. ESA and Cancer, treating anemia in CKD and dialysis, and the patient has cancer. It is very challenging. I'm not going to discuss the mechanisms, but the most important summary of recommendations we'll find in this article of the current issue of seminars in dialysis. So ESAs may be used if hemoglobin is reduced less than 10, if it is chemotherapy associated, not malignancy associated anemia. For patients with multiple myeloma, non-Hodgkin lymphoma, or chronic lymphocytic leukemia, clinicians should observe the hematological response before considering ESAs and to avoid as we can. For transplantation, I think this is one of the important reviews about the latest development in living kidney donation and how to advocate, how to promote live kidney donation. And we hope that we will have in Egypt, because we are still exclusively live, depending upon live kidney donor, to have cadaveric program. But here they even discuss the paired exchange donation. Immunometry, and to know the immune status of the patient, to individualize immune suppressive protocol, I think it's fantastic. And we don't have an accurate immunometry. And this is an initiative, Immunometer, by testing the capability of intermediate monocytes ex vivo. So we have, this is a cluster of differentiation of intermediate monocytes. When they are exposed to Epstein-Barr virus peptides, they release TNF-alpha. And then we can measure them. And this is a study compared 24 cases with proven over immune suppression, opportunistic, recurrent, or malignancy, versus controls without over immune suppression. They compared them regarding the production of the NF-alpha positive cell. As you see, in over immune suppressive patient, the production of the NF is reduced significantly to the control. And this is still initiative, and we want to see further results. Immuno, it is the test of ATP production by T helper cell ex vivo, and it guides plus the immune suppression level, the refining the immune suppression use. If ATP production is very high, this means that the cell is very active and there is a risk of rejection, so increase immune suppression. If it is very low, there is a risk of over immune suppression and reduce immune suppressive protocol. I think it is very nice, even if there is debate, if we can use all these facilities plus what we do from pharmacokinetics and drug level, this will refine the use of immune suppression. Another very exciting is this abstract from the Kidney Week regarding AlloSure. AlloSure is a test that measures circulating free donor-derived DNA. When we have a kidney transplant, the kidney belongs to the graft, it belongs to the donor. So at the time of transplantation, you'll find a higher level of circulating free derived donor DNA that decreases by time. And when the patient has rejection, the graft, which is belong to donor, is inflamed and releases the circulating free donor DNA that can be tested by AlloSure. And this, in this abstract, they addresses we can use serial AlloSure plus DSA to diagnose antibody-mediated rejection to avoid biopsy. It is very fantastic. I read one of interesting paper about the application of circulating free donor DNA after treating antibody-mediated rejection with very intensive immune suppression, IVIG, plasma exchange, rituximab, or others antibody therapeutics, and you can find creatinine is not improved. There is no response. If there is no response, this means either we have still active antibody immunological injury process active, or it is consequences of renal damage. We wanted to know the answer. Is it still the antibody process is working? So in this moment, we can increase the use of different biologic treatment, or it is just consequence of renal damage to avoid the over immune suppression in this context. Functional MRI can, by using diffusion-weighted images, can discriminate between good graft like this one and fibrosis graft like this one. And the capability of MRI is very nice if fibrosis exceeds 50%. Regarding the use of immune suppression and the reproductive health, Here, we don't allow patients, female patients, to conceive while they are treated with either mycophenolate mofetil, mycophenolic acid driving prodrugs like MMF or mycophenolate sodium, or mTOR inhibitors, sirolimus or everolimus. So we stop mycophenolic acid producing drugs 6 weeks and continue on contraception. They are replaced by alloSure, and after 6 weeks we remove the contraception and leave the lady for the chance of pregnancy. So this is for mycophenolic acid. For mTOR inhibitor, it's better to stop 3 months in advance to be replaced by alloSure and continue contraception for 3 months. For lactation, we can allow lactation with, while the lady is on corticosteroid, calcium inhibitors, and alloSure, but we don't allow lactation if the lady is maintained on mycophenolic acid producers or mTOR inhibitors. For the male, should be careful because mTOR inhibitors will be associated with infertility, and there is proposed hypothetical teratogenicity of mycophenolate. This is why the European Medical Agency, since a few years, advised this male recipients to commit to have the sexual contact with condom, and and to shift from mycophenolate to alloSure and continue on condom for 90 days. Although it is challenged by the Norwegian trial, and here in our center at Mansoura, we don't give this attention because we are not convinced by teratogenicity when the father receives the mycophenolate. Very nice. This is the regarding the immune suppression while in pregnancy. Corticosteroid pass freely across the placenta, where 90% is metabolized by placental 11 beta hydroxysteroid dehydrogenase. This is why if the lady is maintained on modest steroid, we are not afraid. In calcium inhibitors, about 70% of the maternal TAC dose crosses over the fetus. The highly lipophilic nature of cyclosporin allows it to diffuse passively across placenta and enter the fetal circulation, but the degree of transfer is uncertain, as fetal cyclosporin concentration range from 37 to this value of maternal cyclosporin concentration. So we should be careful about the monitor of calcium inhibitor levels, and we got the lesson from our professors that during pregnancy, calcium inhibitors are metabolized by two livers, mother and fetal. Mycophenolic acid readily cross the placenta and they exert adverse fetal effects, and this is why we don't allow pregnancy while the lady is mycophenolic acid. AlloSure, maternal and fetal exposure appear to be similar, but fortunate enough that the fetal liver cannot divert AlloSure to its active molecules. So this is why we allow pregnancy on AlloSure. There is limited data about the other immune suppression drugs. Regarding metabolic acidosis, yesterday when we discussed the issue of nutrition, and we addresses that sodium chloride plus sodium bicarbonate increase sodium load. So this is sodium bicarbonate will correct acidosis, but there is potential risk of sodium load. This is why we are waiting the trials of Vivremer. It was proven in this trial, 4-week follow-up of this blinded placebo-controlled study, including this number of patients, 114 Vivremer and 82 in placebo. What is Vivremer? Vivremer is HCl binder without exchanging sodium. So I think in this study, as you see here, the number of patients who developed renal replacement therapy is significantly reduced by Vivremer. So this is the safety of Vivremer, and there is a big randomized control trial ongoing to test the feasibility and the value of using this drug regarding retarding progression of chronic kidney disease. So it corrects acidosis and may potentially be fantastic for retarding progression of CKD. Onco-Nephrology, I'm not going to discuss the different fields of onco-nephrology, but it is a very growing, evolving subspecialty. All renal syndromes can be encountered in oncology. So, and the treating of the patient should include many members. And if you look here, the all renal syndromes, hypertension, electrolyte disorders, all electrolyte disorder, hypo and hypernatremia, kalemia, calcemia, phosphatemia can be encountered in malignancy. And this is an example. And immunotherapy, especially checkpoint inhibitors that are FDA approved in treating melanomas, small lung cancer, and others in malignancy. One of these drugs depend upon immune stimulation. And this is associated with acute kidney injury in native kidney and rejection in transplanted patients. Even in transplanted patients, there are 48 case reports published about the use of checkpoint inhibitors in organ transplantation, and it's associated with real risk of rejection. And if I am consulted, even for transplant recipient, for kidney renal transplant recipient, and the patient, if the recipient has bad melanoma, melanoma is fatal. And in this context, I will agree about checkpoint inhibitors, stop other nephrotoxic drugs. Even we can use small dose steroid just to control this bad malignancy. But the scenario will be very difficult if we are thinking of liver or cardiac transplant. The last 2 points I'm going to highlight is the gadolinium and the risk of nephrogenic systemic fibrosis. So the updated Canadian guidelines, we have 3 generations of gadolinium. The first generation, gadolinium, was associated with nephrogenic systemic fibrosis. But it seems that second and third generations gadolinium are not associated with nephrogenic systemic fibrosis. This is why the case reports of nephrogenic systemic fibrosis are declined altogether. So up to the extent that the Canadian group stated informed consent prior to administration of group 2 gadolinium-based contrast agents at risk is not recommended. Screening even for renal dysfunction is not recommended. So this is very nice data. And the most recent systematic review and meta-analysis addresses a very exciting question. What is the risk of nephrogenic systemic fibrosis in patients with stage 4 or 5 CKD receiving a group 2 gadolinium-based contrast agent? What's your expectation? It is 0% up to 0.07%. So it's 0%. This means that we should stop stop the thinking of nephrogenic systemic fibrosis. The most important, the last point is we shouldn't deprive CKD, dialysis, and transplant patient from vaccination. Regarding transplant patient, we should avoid live attenuated vaccines. We can use a killed or toxins vaccine. However, if we use live vaccines in dialysis, we should postpone transplantation for at least 1 month. We shouldn't use vaccination altogether within the first 3 or 6 months, with the exception of influenza. And live attenuated vaccines should be not used after transplantation. During the period of treating rejections, we should avoid vaccination because vaccination may be not potent. And this is regarding pneumococcal vaccines. We have 2 types, and this is the protocol of using this vaccine. At the end of this presentation, I would like to thank all Nephrology Tanta team, especially Professor Kamal Okasha, for this gathering. The photos are speaking, and this is we enjoyed attending this conference. It's very valuable. I would like to thank Professor Ahmed Shokr for his presence with us, because he's a role model and he helped a lot of nephrologists all over the country. And one of them is Dr. Amr Al-Husseini. He is now full professor in the United States, Professor Ahmed Shokr, for the best giver, because he trained a lot of surgeons to do parathyroidectomy. So this is a very nice act. And our guests from Arab world, from Jordan, Professor Naimat, and from Lebanon, Professor Robert Negm, was our professors and colleagues. And I thank Dr. Al-Mahdi for his photos again and again. I thank Professor Kamal Okasha. And I would like to end by the concept. We don't have excuse nowadays because we have the resources available. This is one of the important resources, a lot of lectures and videos, so no excuse to read. And the data of this conference will be uploaded tomorrow. I'd like to end my presentation by referring to our team at Mansoura. I'm very proud to be a member of this team. We have Professor Onaim, who established a system, and this is very nice to have a system. Professor Sobh is a motivator, and Professor Ashraf Foudans, professors, and all professors and colleagues. From them, we learn the wisdom, and the unit is now under the lead of Professor Ayman Rifai, and with the help of Professor Dunya. And I think this is the best combination for the management of the unit in the history. It was a very nice moment to we are touched, all of us, Mansoura team, are touched by this moment, because when the Professor Sobh was welcomed in this conference, all of us feel that this is for all of us. And as you see here, all of us, the Professor Ashraf Foda is very happy by this tribute for Professor Sobh. I know we are late and I should stop. Thank you very much for attention, and goodbye.